be your host. I'm also joined by two amazing panelists. We have Dr. Elon, hello, and we have fourth year medical student Sonia, hello. A few disclaimers as we enter tonight's session. So one, happy Pride. It's incredibly important for us to make sure that we have this conversation, especially given a lot of national conversation around healthcare access. But most importantly, it's important to us to have this conversation at the end of the month so that we are continuing this work well beyond June. We know there's a lot of work to do to improve outcomes. And it's our hope that this conversation is the start, not the end, of discovering those solutions. The second disclaimer is I am working on the road. One of the reasons why I've gotten very involved in this topic is my own experiences with inequities in healthcare. And we are currently traveling, getting some care for my mom. So just as a heads up to this group, if you're wondering, if I don't know, internet drops, anything like that, that is because we're traveling, but we have a plan in place. And we wanted to make sure this conversation happened regardless because it's very important to us. And then final thing, one of the most important goals of this conversation is pushing for a more inclusive system of healthcare. Inclusivity means having lots of different voices at a table. You will see that we have a smaller table to foster a thoughtful discussion. So there are identities that are not represented in this conversation. It is our goal to advocate for systems that are going to allow anyone from any identity to have better healthcare outcomes, but specifically individuals who are diverse to have the care and support that they need. So if you have questions or thoughts or even your own experiences, please feel free to share them in Q&A and chat because we want to make sure that we are being as thoughtful as possible in our conversation and our discussion. With that said, we are going to get started. So Dr. Elon and Sonia, thank you so much for joining me. I have an initial question to help get us started, and that is sort of focusing on why this topic. So Dr. Elon, can you tell me, how do personal and community identities impact one's experience with healthcare? What is the impact of being a person from the BIPOC or LGBTQIA community?
Well, good evening. Hi, Natisha. It's good to see you. It's a very interesting topic for me for different reasons. I am part of the LGBTQI plus community. I am a person from Latin America. I am a physician. So I have when we start talking about the intersections of identities, I think this is one of these places where I think it is very important to see where the disparities are growing, or are happening in the healthcare system. So I have my personal experience, and I have the experience of my friends and chosen family, and I have the experience from the perspective of a healthcare person providing healthcare, and so. That's why for me, this is a particularly important topic because I do see how for my fellow colleagues, physicians, medical students, how this topic is usually, 3 or 5 hours long in the whole curriculum. And I feel like this is especially, after coming out of the year that we've had, one can see how blatant the disparities are. For people of color and the other marginalized communities that are, compounding these identities that makes it really hard for people to get really good health care. I don't know if I answered your question.
Good. I think one of the words that you used is disparities. And I think that's such an important thing to highlight because in recent years, we've had the opportunity and the ability to really start to advocate for where, despite the expectations of a healthcare system is, I go to my doctor or I see my healthcare provider and I receive fair care. What we actually see is that there are disproportionate impacts to specific communities based off of race, gender identification, sexual orientation, and multiple other identities in terms of how their care gets impacted. Sonia, are there ways that this has come up for you, ways in which you have seen disparities for individuals depending on the community that they're from?
Yeah, so for me, I actually started my clinical rotations during the pandemic. So I think that managed to highlight a lot of disparities, even more starkly than I would have expected. And it raised a lot of questions that I realized that people above me do not ask in general or do not think about. And it's from like small things like, oh my God, we have to use a translator for this patient to like, oh, like we have to do a sexual history. And it always rears its head. And I think as like someone who's going to become a physician, I think it's really important to me to like see these changes sooner than later in my lifetime.
Sonia, what's a change like that you really want to see, like a disparity that you've seen recently that made you go, man, I can't believe we haven't changed our approach to this yet?
One thing that I really want to see a change in is the approach to requiring a translator. If someone needs a translator for Spanish or French, those are two of the ones where like people don't necessarily complain. But even today, like I had a patient who we needed to use Vietnamese, and my resident and my attending were like, "Oh my God, like this is going to be so difficult. It's going to take so long to get a translator," and the delays in care, the frustration that like comes with all of that, and like seeing like it's very clear that it impacts the care from the very beginning for these people. And especially when you bring all of the other disparities into it, it doesn't help matters. And I think that communication is one barrier that comes up, whether it's through issues with translation or with not being comfortable enough to take a sexual history properly, not being comfortable enough to ask tough but important questions. And I think that, well, that's something that's never really going to go away. So communication really, like, that's a good place to start, I think.
Can I also I think that you're saying something very interesting, Sonia, about communication. I think language in general is a very important aspect of, you know, of feeling these, we're talking about microaggressions and macroaggressions regarding healthcare delivery. And, you can see it from even from the very beginning when a patient comes into any sort of facility, be it a hospital, a private physician's office or anything like that. When you first start to fill in all of these forms, in the one of the first things that they ask you, what is your name? And so for example, for people who have a trans experience, who have people who are non-binary, a lot of people change their names, and there's not a lot of support necessarily in states regarding name changes and stuff like that. So you immediately start feeling this sort of microaggressions where you have to use a name that you're not comfortable with because that's your legal name. So I think that it's very important what you're saying about language and communication, but the barriers start even as the person is, trying to make an appointment and trying to go through the door just to get some kind of care. Natisha, I think I maybe interrupted what you were going to say, but I just thought that this was a very important point to make.
You did not, and I'm going to keep you on the hook a little bit longer. So two things that I heard from both of you, almost two sides of a coin. One is, how do microaggressions show up for patients, and what does that mean for the care they receive? The other, though, is how do implicit biases show up for healthcare providers, and how does that impact their perception of the care they're going to give? So Sonia, in the example you provided, you noted like an immediate reassessment of a level of difficulty that then maybe delayed care and even changed the way the approach to care was given. Both of those seem like particularly risky items, and so I wanted to touch on both. So Sonia, I will ask you, what are some of the ways in which microaggressions then impact how individuals perceive the care that they're receiving, and how does that actually impact the level of care that they're able to get?
I think it like really makes them feel like closed off from the very beginning. And like what Dr. Elon was saying about the, just from the very beginning, what gets put in your chart Like if you have Epic or a different EMR, like you'll definitely see their legal name, but you won't necessarily see is what's the preferred name, what's the preferred pronouns. And one thing that I think should really be put in is, especially for pediatric patients, is this person out or not? I have had patients where I wasn't sure if the parents knew about the preferred name and the preferred gender. And I was put in a situation where I was like, I don't want to out this person, but I don't want to use the wrong pronouns. And when I brought it up to my team, they had never, ever thought of it before. And part of that has to do with where I am, but that shouldn't be something that had never been thought of before, because that's definitely a situation they had to have run into at some point or another in pediatrics. And I think stuff like that, just thinking about the small changes we can make to like patient profiles in EMRs, that can really like change the beginning of patient interactions, having those specificities put in there. And especially for people who are transgender, having like the necessary information put in about, like, where are you in your transition? Because that will impact your care. It will impact what screening you need. Having all of that be normalized as something that's necessary to be asked from a medical standpoint, I think that stuff like that will really like just create better, more open, more normalized care.
Thank you, Sonia. Dr. Alon, from your perspective, what happens on the provider side when implicit biases start to creep into how they're approaching a patient conversation?
That is such a good question. I think we could talk for hours about implicit biases in the healthcare system and where does it start, right? I think a couple of years ago, there was a huge study that was made that did a sort of study on first year medical students who self-identified as heterosexual, and what they felt towards treating patients who were in the LGBTQI plus community. And more than 50% of those students said that they were uncomfortable treating patients who were a part of the community. And so you see there from the first get-go how that kind of discomfort is, if not attended to or not, there's no education that's provided or experiences that are provided, and that sort of escalates through the years as they are becoming physicians, right? So there's the explicit biases that are more, outward and more sort of conscious, and that people usually tend to check more. But what about the implicit biases? You don't know what you don't know necessarily, and I think there's something about, it's the same sort of effort about being anti-racist instead of just being not racist, right? There's an effort that needs to happen, and that effort needs to happen from medical students. It needs to happen from the institution point of view. It needs to happen with professors about how we're tackling those implicit biases. And so what that means is basically trying always to challenge oneself. I start, I'm part of the LGBTQI community. I'm a non-binary person. I'm a physician. I'm a Latin person. But that doesn't mean that I know or of all the experiences, nor can I talk about all the experiences in the rainbow of, that exist. And for me, it is always a challenge that I need to continue to educate myself. And it's a challenge all the time, because I grew up in a community that gave me an education where I have implicit biases that I'm not aware of necessarily. And so it starts with questioning yourself about what are the things where I can grow, and what are those biases. There are a couple of tests, widely available that one can start with as an individual effort. But I think that as medical educators, this is something that we need to, I think, give time and effort so that we can create a more equal sort of healthcare for our patients. And so it is a very important topic. And I think that this is something that I care very deeply about. So I could talk about it for a very long time.
I want to, Elon, something you touched on that is incredibly important, and it's something I've seen in my own life, is many doctors and healthcare providers, nurses, come into the field because they want to provide care to everyone. And I start by saying that because I think many people have the tools that they have. And so the point that you made, if you just don't know what you don't know, is really challenging. And so at its core, how are individuals educated about these issues, and how are they provided with fair information that allows them to make assessments of people's needs and care? That seems like an incredibly important component. We have a note in chat from Susan, who noted that in her nursing program, there's a smaller focus on LGBTQ plus individuals, and it only comes up in the mental health textbook. I know, Dr. Elon, you noted that in some cases, individuals might spend 5 hours or so on a topic that feels incredibly important. And I know, Sonia, you've seen this come up as well in terms of the amount of information that is shared and where it comes up. So I want to sort of take a moment to ask the question, what are the ways in which the way that we educate healthcare providers might be providing information that does not allow for equitable treatment? And how can we start to shift that and or build awareness that it's happening? Sonia, I will start with you.
So I think one of the biggest things that we can do is realize that the people who are accepted into medical school are not coming in with the same level of understanding, the same experiences. So it's dangerous to assume that people are starting from a place of, like just knowing what disparities are there and how they impact people's mental health, how it impacts their cares. And even just assuming that the people who come in and are starting in the healthcare field are okay with people being LGBT. I think creating like a better education during the first and second, like the preclinical portion of care, of learning, that would really make a big difference, as opposed to, just learning when you see what's messed up in an actual patient, and not being aware of those biases, of those disparities ahead of time, and not understanding the impact that they can have. Because I think we just have this very dangerous assumption that people will learn when they learn, as opposed to this needs to be a set thing. Because understanding the things that impact all of your patients, for be it their identity, be it their race, be it their culture, that's just as important as, their allergies. Like it should be a set thing in preclinical teaching to understand how that impacts your patient's care.
I will follow if you want, Natisha. Because I think this is a very important topic in terms of medical education, which is what I'm familiar with. And I think that's not very dissimilar to what happens in nursing, dental school, PA school, and other places. And one of the things that I think about is like stereotyping, right? If I tell any medical student about risk factors for a gay man, everybody's going to come up and say immediately HIV, because that's what we are used to seeing everywhere in Hollywood, for many years. And in fact, that's not the only risk factor for people in the LGBTQIA community. We have a higher incidence of cardiovascular disease. We have higher incidence of asthma. We have higher incidence of suicide. And I think that there are all of these stereotypes that we sort of are, I received that as well in medical school. These are the stereotypes because it is easier to learn this way. And so you sort of put people into buckets, and that's that's the risk factor, and that's the only thing you know. And one of the things that I think can be helpful when you are having when you're educating yourself, I don't think it has to be only from the preclinical years, though it's very important. I think it has to come even after you're already a doctor and you're doing other things, is contact with the community, is listening to the stories. I think as human beings, there's something that we learn when we hear the story and we can relate to people. We have more in common than we have differences. And so I think that having people, when we're doing the experiences with patients, bringing LGBTQIA people with all the spectrum of experiences to have a more real conversation and having interactions and having I think that creates some sort of normalization where you see, oh well, this person also has a problem trying to get housing, or this person also has the same problem that I have, is that we don't like the same kind of movie. It's through experiencing as human beings that we can start creating relationships, and that normalizes some of the and sort of breaks down some of the stereotypes that are so ingrained in medical education.
Thank you, Dr. Elon. Thank you, Sonia. I would also add, probably asking yourself when you're doing your own research and your own data, who's represented in that data. So for example, it's easy to say the AIDS pandemic is one in which we saw science help us shift numbers and results, which is true. That's not true equally across all communities. So there's data that tells us right now people of color who are part of the LGBTQIA community are still more likely to die from AIDS than a white individual as part of the LGBTQIA community. And so also I think having the ability to ask ourselves, what does this data tell us and where's the data coming from, is incredibly important. Another step that one can take, and a question from our audience, is about language and how to leverage language in a way that addresses microaggressions. I think, Sonia, to the point you made earlier, like what's the value of communication and how communication either be a tool to help us or hurt us? So the question is, on the topic of language and microaggressions, is there something to be said for gender neutral language or asking about preferred language in general? For example, an OBGYN referring to their patients as birthing persons versus defaulting to calling a patient mama or mother. I think there are actually varying opinions on this in the medical community. So Dr. Elon and Sonia, I would love to hear your thoughts.
You can go ahead, Sonia, if you want.
I think I'm all for like the gender neutral approach, be it in OB. In general, like if you start by asking someone, oh, do you have a partner? That's going to go a lot better than I think asking, do you have a girlfriend or do you have a boyfriend, based off of the gender that you see in front of you. You could very easily close off someone who would have potentially trusted you and like let you know their identity, would have you could close yourself off to a part of care. And honestly, like on newborn nursery, I saw a lot of, they called it mommy talk. You would walk into the room, it would be the mom and the dad, and it would be like, first of all, why are we calling this mommy talk when there are two parents? Call it the parent talk, call it the new parent talk, call it something else. We had a gay couple who had just adopted a child, and they still walked in and they were like, okay, it's time for the mommy talk. And I was like, what? I don't know what you're doing or why you're saying it like this. Just say, this is the stuff we want a new parent to know when you take home your new baby. This is the stuff you need to know as a parent. It adds all of these layers of assumptions on who needs to know this information, whose responsibility it is to be a good parent. And I think that honestly, like, you introduce biases just from that one assumption. So if you can make something as neutral as possible and leave it to your patients to let you know where they stand in any way, shape, or form, I think if you don't do that, you're doing your patients and yourself as a provider like a huge disservice.
Dr. Elon?
Well, I think, I think here I can tap into my very own personal experience as well as a patient, as well as the, some of the stories that I've shared with my friends. We know that LGBTQIA plus people tend to avoid going to their doctors. And, we always associate when we talk about LGBTQIA healthcare, everybody associates with mental health and HIV and some very like stereotypical buckets of things. But what about people who need to have a pap smear? What about people who need to have, they're 50 and they need to have whatever screening they need to have? So I think that we need to provide a safe environment. This is a one, like, part of the first classes that you get in medical school about how you have to make a safe environment so that your patient can trust you. And so language is one of the most important things. People in the LGBTQIA community feel very nervous about going to a doctor who's not going to acknowledge who they are, and not allowing the person to present as fully as they are. And so that's one aspect of it. From the perspective of medical students and physicians, I think it is a good exercise in checking our internal biases, to try to be as neutral in your assumptions as you can about gender, about roles in households, about all kinds of things, so that you give the opportunity to the patient to express how they want to be addressed, how they want to be, what are the roles. There's such a wide variety of families and family relationships. Why are we always assuming that mom is doing this thing, dad is doing this thing, and that's the only sort of format that we're used to? And so if we start as medical students and as physicians to trying to neutralize our language, to give space for the patient, and sort of like in a more curious and more, because that's, we're detectives, right? As doctors or medical students, we're trying to find out who this patient is, what is happening to this patient, and what are the contributing factors to whatever it is presenting in this moment. So if we are neutral and we are open to the patient telling us who they are and telling us their story, I think we're going to get much more relevant and important data, and we're going to have a better relationship, which, statistically speaking, is going to be directly impact outcomes for our patients. So I think that language is the basic thing that we can start checking in how we are having relationships with our patients.
And I think the point about relationships and trust is so important, because in many underrepresented groups have challenges with the medical community. So a woman of color, or someone who identifies as a woman of color, who also does not identify as part of the heterosexual community, that individual has a higher chance of walking into a doctor's office with fears of mistreatment and miscare, and also has a higher chance of those fears being accurate. So I think understanding the role of the right questions at the right time with the right language, and how that can make a huge impact in shifting the way someone views the care they're receiving, then can change how one person views a doctor. And that one person changes how their family views a doctor, right? All you need is one person in a family to start going to a doctor more for that to change a community. And so I think sometimes these problems can feel very big. How do you fix this? But one positive interaction with one patient can make a big difference. Whether you're a nurse, an administrator, a doctor, it can make a huge difference in outcomes. I want to turn to an audience question, because I think it's touching on a topic that we're discussing, and that is balancing general information with individual information. So one of the things that we've continued to highlight is the importance of recognizing that many of the practices that might be deployed actually rely on generalizations and do not focus on individualized care. The question specifically is, would we say that what's being taught in medical school is based more on generalized ways to treat versus an individualized approach, even if patients are under the impression they're receiving an individualized approach? I'm going to add to that question, though, and say that sometimes people use generalizations in ways that they hope are helpful. So, for example, there's a generalization that currently has spurred a very important conversation. Black mothers are more likely to die in childbirth. And that has led to a conversation of why is that true? So I think that it would be reductive to say that generalizations don't have any value, but they have a value to a point. So how do we balance important community level understanding of factors versus understanding individuals and what they need? Sonia, I will start with you.
So I think generalizations have their place, but they just they create like all of these little boxes that can just impact care from the very beginning. And one of the best examples I can think of is in medical education, the preclinical years, at least for medical school. Obviously, I can't speak to nursing school or anything like that, but it's all geared towards passing your board exams like step 1 and step 2. And the language on those exams is all about being like, this is the typical patient you would see with this presentation, which is almost never what you would see in real life. But we always would have like a question on an exam that would start with the exact words, a 30-something-year-old Black woman comes in, and immediately before you read the rest of the question, your mind was supposed to go to sarcoidosis. That was how medical education is. And honestly, like, first of all, that's just a terrible way to approach things, to be like, this is the exact type of person that is going to have this illness. That's not always going to be the case. But it's important to recognize where there are increased risk factors, definitely, right? Like, it would be dangerous to not say that, like, people of color would be at increased risk for suicide, at increased risk for certain things. Like, you have to acknowledge those, but not, it's like finding that sweet spot. And I mean, obviously at my point, I can't say where that sweet spot is, but I can say that we're not hitting it in medical education.
Well, I think it is true that, the balance, I think, like everything in life, it takes practice and experience to reach that balance. And one of the things that that I don't know, that always has had value for me when treating patients is, you read the cases in the book, and you don't bring the book to the patient, you bring the patient to the book, kind of thing, where it is true that it is, data is very important because it informs trends, it informs about how certain particular populations are being impacted by certain things, social determinants of health and all of that. But I think that in the moment when we are one-on-one with our patients, we have to be cognizant that they don't represent necessarily a group of people. It's just their own person. And so when you start by doing the effort of being very open and very neutral and very trying to quelch down your own biases and assumptions about a person, and letting the person tell you who they are and what are they doing in their lives, that will also create a space where individuals are then really getting the individualized care that they deserve. So I think that the balance is about, data is important as in that, brings generalizations that can be very useful from the perspective of epidemiology and all of this. However, we also have to understand that those are numbers that are helping explain a problem, that are not necessarily completely getting rid of the problem. It's a way to tackle intellectually and scientifically how we can do things better, that it can guide how we are doing treatment, how we are attacking whatever it is that we need to confront. However, we have to always remember that we have a person in front of us when we're treating patients. It is a person, and whatever they bring into that room when you're sitting in front of them. And I think that is one of the things that's missing in our healthcare system here. When you come into the doctor's office and they barely look at you because they're so focused on, finishing their notes or whatever, that they don't really listen to what the patient is trying to tell you. And so I think it is about that kind of attention that can start to bring some change in healthcare. In my obviously this is my opinion, but
I have a follow-up question from the audience, and then I'm going to pivot us to some questions around how we can start this work with med students. We have a lot of questions around how to get engaged and how to get changes and outcomes. So the follow-up question is, is there a distinction between acknowledging potential health risks and assuming health conditions? From both you and Sonia, it sounds like the answer is yes, there is a distinction for doctors and nurses and healthcare providers. That said, I'm sure that it feels like when you're making an assumption about health conditions, it probably feels like what you're doing is acknowledging health risks. So my question is, what is one thing that a healthcare provider could do to check themselves on whether or not they're making an assumption, which is hurtful, or they're acknowledging a potential risk, which is helpful? Sonia, I will start with you.
I think the best thing that like a provider can do from that perspective is just, even if you like walk in and you're like, oh yeah, this patient definitely has this thing, we're still supposed to be like, look, this is my differential. Why is this the most likely thing? Why are these less likely? And I think that really sticking to that is a great way to like check yourself and be like, okay, like just because I think it's this thing doesn't mean it is. Why am I ruling out these other like really concerning things? And honestly, like I've definitely like seen a patient and in like 2 minutes been like, oh yeah, this has to be like a PE, or this has to be this. And someone always asks me, but why isn't it this? Or why wouldn't you say it's this? And I think that as long as we are able to do stuff like that, we're definitely able to check ourselves, but that doesn't stop, like a lot of the biases that comes in with acknowledging the risks as opposed to just acknowledging the trends that could impact your patient. Like, I guess that sort of distinction, like differentials and stuff like that, that helps, but it's not enough.
Dr. Elon?
Well, it is a, I don't think it's a simple answer, because there's so many instances where we're making decisions in very short seconds. And so the biases, and it's kind of hard to check those at the door and be, truly an open and neutral person when you're dealing with patients. But there are a couple of things that I think can start creating sort of the language and the relationships that I think would be very beneficial for everyone. For example, when, part of the medical, doing an anamnesis or asking a patient about, for example, if they use drugs, we have these sort of like pre-selected questions, and we always do the same kind of question in the same way that has such a negative connotations. Instead of saying how many cigarettes do you smoke every day, and then pass to the next question, and then pass to the next question. One of the things that I think is important is to say, what happens when you smoke? What do you feel? Why do you feel better when you're smoking? Because there's so many assumptions that you have, like how many drinks a night are you taking, and what does it feel when you drink? I remember a case, for example, of a patient who had an alcoholism problem, and nobody asked him why he was drinking. And it turns out that this patient was in pain every night, and he had back pain every night, and he drank because that helped him sleep. And it turns out he had a disease that was affecting his spine, and that's why he had been drinking for so many years. But because nobody took interest, and and every time he said that he had a drink, he was shamed into it. Then nobody really understood that there was a base layer problem there, and it was never treated. So that's a very basic, sort of an example of how things and how we can reframe some of the questions that we have. There are risk factors, but what are also the things that make somebody potentially be a promise of something better? Why aren't we asking also, what are the things that are working in your life and how we can make those things better so that you can have better health? So I think that there's a framing there where we're always focusing. I'm not saying that we're going to take them aside because these questions are important, but I think that there's a reframing that can happen, and it has to be very, conscious and very, you have to be very precise in how you are doing things so that your patients can really tell you their story, and so that you can start putting those biases on the side.
Thank you, Sonia, Dr. Elon. One of the ways I think we can reframe the medical experience as a whole is to start earlier, to start to shift the information and advocacy at the college level, at the pre-med level, so that we continue to have doctors and nurses and administrators who are more educated, more aware, more inclusive. That brings me to one of our audience questions, which is, what can we do to bring up these discussions on campus in undergrad, given many students in the science departments are on the pre-med track. And then a follow-up to that is particularly like, how can people navigate this when engaging on campuses that are more private or religious? Sonia, I know that you're currently in an area that is particularly rural and not inclusive. And so I want to ask you this question first.
Yeah, honestly, to preface, I am in like an area that genuinely, if you see a person of color, it's very, what are you doing here? But basically, you know, when someone like in your education, there's always going to be things that come up. I think it's definitely difficult at the undergrad level because you might not know what questions to ask or kind of what generalizations there are that are harmful. But I think so I can't necessarily speak to that, but I think for like a preclinical setting or just when you're in like a school for healthcare, I think the most important thing to do is to just ask as many questions as you can, make the people above you realize that like, oh, there's something we're not getting here, something that like we haven't thought about. Like with my attendings, whenever I'm like, okay, these people don't know how to deal with an LGBT person, or these people are just like, they're not thinking about the impact of this person's race. They're not thinking about the impact of this person's religion. I always ask them like a very pointed question for like a very like oddly specific example. Like I had a friend who wasn't on PrEP, and when I asked why, he was on his family's insurance. He wasn't sure how the testing for that would show up, and he didn't want to get outed. So I was at an HIV clinic, and I made a point to ask the attending, like, what do you do if someone is under 25 on their parents' insurance and is afraid of taking something protective like PrEP because they would get outed? And she just looked at me and she was like, no one's ever like come to me about that. And I was like, well, did you ever ask? Like, you have plenty of people under 25 in your clinic. And she genuinely had just never thought about it. And that's the thing, like, that probably never would have come up unless she would initiate it. And so I think really the best thing you can do is ask questions, make people aware that there is a gap. And, you know, eventually when enough questions are asked, they kind of can't ignore it anymore. And they have to acknowledge it. So be annoying, be a thorn in their side, and force them to acknowledge when there is a gap.
Dr. Elon, what are your thoughts on how current med students or pre-med students can start to influence the future of healthcare in this way?
I'm very hopeful for the next generation, actually. I don't know. I feel like they're a very brave new generation. So, I agree with Sonia. Asking questions is always important. And I think if you're not part of the LGBTQIA community, if you're not a Black person, if you're not a Latin person, if you don't belong to any of these like pockets, these communities that are usually undersized of a lot of issues, I think that you have sort of you can start by checking your own privileges and starting to speak up, because usually what's been happening a lot is that you have, you tokenize people. Oh, this is my Black friend, so I'm going to ask my Black friend to train me and tell me what their experiences are, so that I can understand. And so it's about doing the work yourself without putting it on other people. It's about being brave and standing up and saying, hey, I think that this is going to impact other people, because one of the issues that I see is that as part of the LGBTQI community, even when I go to a doctor and I see the sort of the microaggressions that I'm treated with, I'm a non-binary person. And so for me, I'm in medical education, I teach clinical skills. And so I know how this should interact, and I still have a problem in speaking up for myself. Sometimes it's hard. You don't want that kind of attention. There's so many layers of history that comes for all of these individuals. And so it is sometimes very hard that to speak up. So if you are not part of these communities, is also very, that's the difference between being an ally and being a co-conspirator, right? Is that you speak up, you stand up, and you try to help in ways that doesn't put the attention on the people who are already marginalized. So that's one aspect of it. And I think that that asking questions is one of the most, like, you're learning, and you should demand, like we tell our patients that they should demand information about their care. As a student, you have a right to know why things, ask the question, why are we doing this way? Sometimes because of how things go, nobody has really stopped, like what Sonia said. Nobody stopped to think that maybe this was something that needed to be attended, and maybe have some sort of answer for a patient, or a procedure that we can do to help a patient and protect this patient. So I think that be curious, be brave, be a friend, I don't know. I think there's so many things that you can do at every level. And so I think part of my faith in the new generations is that I see that this generation does ask more questions, is more sort of brave and courageous in speaking. And I hope this maintains, because we need this generation to do that as well.
Dr. Newman, I love that you highlighted the value of learning and speaking up, especially those who are in ally positions, because representation always comes up in these conversations, and it is incredibly important. Do not get me wrong. I want to see all backgrounds as part of healthcare. And I do believe that communities are more likely to open up to physicians and nurses and healthcare providers who they feel understand their background. And it's meaningful to see someone who looks like you. That said, most of our current doctors do not come from the communities that we are investing our time in talking about today. And so it's not enough to increase representation by 5% or 15%. We need to make sure that everyone gets the right care they deserve. And so that starts with intentional effort and thoughtfulness. On the other side of the coin, for people who want to get involved in the medical community and want to take a next step and explore pre-med or med career, being at a place that's aligned with your beliefs is also really important. And so we have a question from the audience on how do you find a school and institution that is authentically engaging in this work? I know that there is probably not one perfect answer to that, but Sonia, do you have any thoughts on ways in which someone who cares about this and is trying to find schools who are engaging in the work, like what are things they could look for that would help them make that decision?
I think one of the things that you could do for that would be to kind of, when you're reading up on like a school's website or like a program's website, you'll see kind of very clearly what it is they prioritize, or at least like what they want you to know about. If the first thing you see on their page is like, we have this percentage of like women and this percentage of people who are like of color, then you're like, okay, you're just doing this to like meet whatever like quota you think you need to not be in trouble. But if you look at like their thing and it talks about, let's say they have a foundation of patient care class. That's what my school had. If they have something like that and they go to, will touch on like the disparities brought about by like biopsychosocial issues. If they mention like if they mention specific disparities, I think that's how you kind of know they care. Truthfully, I chose the same med school like years ago, so I didn't know for sure if they shared my beliefs. I just signed on at 17 and said, take my money. But as I'm looking at residency programs, I'm seeing places that some of them are like very clearly don't care about stuff. Some places will like very clearly mention issues with mental health. And I'm like, okay, so you care about your students not being burnt out. You care about them as people. So I think the stuff that gets mentioned in programs and on schools' websites will really tell you what it is they prioritize and how much they care.
Thank you, Sonia. I want to pivot us because as much as I hate saying this, our time is slowly coming to an end, which is always my least favorite sentence, especially when having a conversation this important. There are two aspects of change and reform that have come up from the audience I want to make sure we address. And so one of them is actually around technology. Something that has come up, and audience, I'm going to summarize because there's been a few different threads, is the notion that as much as we can change personal behavior practices, lots of the systems that we use to take information about patients have not changed in years. And that is the information that gets transferred from hospital to hospital. That is the information, especially if you're trying to go see a specialist or you've been referred, is the information that everyone has access to. And so there's a question of what is the role of technology in creating a more inclusive environment? And what are the changes that we need to see for technology to be serving communities versus creating disparities in communities? Dr. Elon, I see you thinking deeply, so I'm going to pass this question to you first.
Yeah, that is a good question. I think technology is I think going to have an important role in healthcare. I mean, we've seen just now in the pandemic how healthcare delivery has changed a little bit with the openness of telehealth, right? And so that is the support of technology. And so one of the things that I've been struck by, because the pandemic sort of shift perspectives on how we could do things, is that healthcare is very doctor-centric in a way. You know, we are in a particular place, and the patients come to us. And when you think about patients who have chronic issues, patients who have mobility issues, patients who have all kinds of, you know, monetary or financial issues, how difficult sometimes it is to even go to the place where they're supposed to get the care, right? And how technology has facilitated some of this in that then the doctor is more in your home in your own comfort place, or comfortable place, hopefully, so that we can sort of start addressing some of these issues, right? And so technology, I think, is going to hopefully play a very important part about how we are going to be delivering healthcare. And one of the things that I think, you know, I can think of technologies about how do you do an intake, and how you can, like how we do these forms that sometimes can take like 40 minutes while you're filling all these forms about your history and everything else, and how we can change and shift some of these things so that it becomes more neutral, more open, and has the ability for the person to really tell, you know, in a more like sort of individualized and private way what they want to tell the doctor about themselves, so that they can, you know, feel that they're not being judged, or that they're stigmatized because of the answers that they're giving. So I think there's different efforts and different things that are happening currently with technology and healthcare, and that I'm very hopeful will try to, you know, I am hopeful that this will be far-reaching. You know, if we start thinking about people who are in remote areas, and the possibility of a telehealth consultation with a physician that previously they wouldn't have any access to. So that, for me, that's already starting to feel more encouraging. When we think about rural areas and people in the LGBTQI community who are denied, because it's not even that they're avoiding healthcare, they're denied healthcare because of religious reasons or for anything else. And usually there's no alternatives for people in these pockets, in these communities. So having things that are, you know, like telehealth will bring hopefully some care for a person who previously, in previous years, would not have any access, absolutely any access to healthcare. So I'm hopeful that technology will help us out in maximizing where we can reach.
Sonia, are there changes in technology that are happening right now that feel exciting to you? And are there changes that still haven't happened yet that you really want to see?
Yeah, like I think I kind of mentioned this earlier, but like in the EMR systems, when like it has like we have preferred pronouns now on there, but we don't have like a lot more designations to really like help providers like have a picture of like a profile information about their patient before going into a room, and that sort of stuff. Like my hospital actually has like Epic consultants, so I've like spoken with them. Obviously, I don't think they took it as seriously from a medical student as opposed to an actual provider, but I told them that I think there are gaps that like they should discuss with their like the people who like the whoever their point person is for the EMR system with Epic for specific changes for the hospital. Because I mean, I know they have them because there's constantly changes. And I think that that's kind of a great thing for like when you notice that sort of gap, not just asking questions, but telling the people who actually can make those changes happen, like letting them know that you think that's important. And honestly, like in medical education, stuff like this very like this Zoom, it's great, right? It's helping people think more about these sort of things. And medical education, like if you add to a curriculum a couple podcasts that touch on these sort of topics and you make them part of the curriculum as opposed to an optional thing, then the people who need to hear it will hear it, as opposed to just the people who are already interested in it. And like at my school, like we had a thing that really got into a lot of transgender issues. And I know that the people who showed up were the people who I already knew had a lot of questions going in, as opposed to the people who didn't know that they should have questions or needed more information. And so I think we need to change what we consider to be mandatory learning. And I mean, there's so many things out there, like there's so many medical podcasts, like if anyone's like heard Dr. Death, like that makes you rethink like physicians protecting other physicians. And I'm sure there's plenty of other out there that touch on these topics. And if not, I would happily make one and just rant for hours. So I think, we have the ability to use the technology that's out there to bridge a lot of gaps. And, hopefully we can start to do that a little bit more. And the pandemic definitely did make a lot of transitions to technology a bit easier. So, maybe COVID did one good thing and will make technology even more integrated in teaching.
Sonia, I think I speak for all of us when I said I've definitely listened to you rant for hours. But we are at our final question of the evening, and that is one of the things that I believe is that healthcare is not in a silo. There is no boundary between healthcare and your life. What you learn in your educational system becomes your healthcare, right? So your sexual education class impacts what you advocate for, impacts how you understand your life, and it impacts your healthcare. The food and water you have access to impacts your healthcare. And so that also means that the healthcare community has opportunities to de-silo the way they think about the work that they do. As we start to wrap up tonight, the final question is, what are ways that healthcare providers can either get more involved at a community or legislative level to make a difference? How can we make this change, not just within the offices or hospital beds, but within communities, so that we are reaching everyone who needs to be reached, even those who might not be trusting enough yet to show up to the doctor office? I know this is a big question, but a very important one. So Dr. Lalonde, we'll start with you.
That is a very, very big question. So, I think that the people who are participating in the healthcare system as like giving healthcare to people, it's about checking your own implicit biases and doing the work. I think we get too comfortable sometimes with our experience and we think that we know everything. And so it's checking ourselves on an individual level. It's being advocates. It's, there are a lot of, and it's being involved in the issues of the community. And I think representation is very important. So we have to create space and give space to the different voices that are already part of the healthcare system and who, like, doctors who are coming from Latin America, doctors who are Black, doctors who are from the LGBTQIA, people who have intersectionality and all of these. Those are people who need to be sitting at the table, not as a tokenized person, but as a person who is part of the decision making, part of the thinking behind decisions that are being made in terms of policy. And we need to start advocating for our patients and for our communities. And so I think that it goes all hand in hand with education and also the will of everybody who's involved, who is touched by this, by these subjects and by everything that's happening in the United States in the last couple of years. should be part of the conversation and try to, further create space and check your own boundaries and check your own, I don't know, how can we move forward? If I know that I'm in a position where I can make decisions, how I am empowering the people who are coming behind me as well, so that they have a place at the table. And how can I create a space at the table for myself as well? So there's a lot of work to be done. And I think that what we should be is we have to be activated. We have to be part of this amazing change that can be done. So I think that's how I think about it.
So yeah.
Honestly, I think the most important thing is remembering, like you're not working on a patient, you're not working on a group of people. You are meant to be working with them and for them, and in order to do that, you have to know what their issues are. And you will have those disparities will show up in individual patients, and over time, you will realize what's important to you and what you want to do to change it. It's a matter of having the tools. I'm getting my master's in public health so that I can have those tools. And I'm loath to say that an additional degree and an additional amount of tuition is necessary. But I think you just have to do whatever you need to do to feel like you can get involved in whatever facet of this that you want to. If you want to do administration, do it. And just don't fall into the whole hospitals are a business kind of mindset. Don't become part of the problem by when you're trying to become part of the solution. I think that's the most, honestly, that's probably the most important thing, I think.
Thank you so much, Sonia, Dr. Milan, and thank you to our audience. I was not able to respond to everything happening in the chat, but the chat was incredibly engaging. Everyone sharing ideas and thoughts. And so I thank you all, not just for coming here and listening, but truly being a part of this conversation. I will echo the fact that I believe that there's hope in this space. I believe that by addressing the inequities, we don't address them just to say like, these things exist and that's what it is. We address them because we believe we can change them. And I want to thank Dr. Milan and Sonia for providing really thoughtful steps that we can all take to start to make a difference, to build an equitable space where everyone is getting the care they deserve. I thank you all for joining me tonight. I hope that you end Pride Month with a bang and have a great time. If you're doing any events, enjoy yourselves. We thank you for sharing some of your Pride Month with us, and we look forward to seeing you at our event in July.